Thank you. Thank you very much, Chanel. First of all, welcome and good morning to each one of you. I hope you all had a good and a healthy morning. I see from the list that many of you attendees are our regulars. Huh. Regulars, I mean returning participants who attended probably about half a dozen of the COVID-19 related webinars that we delivered last year. Uh, Little bit about ECHO, as most of you, if not all of you, know about us. We are a 21-year young company involved in professional consultancy in environmental and occupational health matters. And as Chanel mentioned, I am the proud founder CEO of this esteemed company that's providing professional advice with respect to COVID, following the industrial hygiene principles of recognition, evaluation, and control. So that's about me. And let me just introduce some of my other colleagues and the other speakers. Next slide, please. Uh, this There are three speakers. You have read the bios in the MailChimp that was sent to you earlier on before you registered, so I won't go into any great details. I will be the first speaker, and I will have some general comments, something similar to talking briefly about the state of the nation. I have two of my esteemed colleagues who will do most of the talking. Yes, if I shut up and give them some time. Anyway, to our regulars, they are no strangers. Marianne Levitsky, my colleague of last almost 40 years, and that if gives you my age, I don't mind, but I like to respect hers. Our senior industrial hygienist associate, she is the former director of WSIB. She is the founder president of Workplace Health Without Borders, a charitable organization that we at ECHO support, an adjunct professor at the University of Toronto. Uh, I can go on and on, but I think I will stop here. My other colleague that will be joining us is Rob Fernandez, my very close colleague of almost 21 years. At ECHO, he is our Director of Health and Safety. He's a certified industrial hygienist and with so much of practical and hands-on experience to support our clients from all walks of life. So that's the team that's going to be presenting today. Next slide, please. COVID-19 2020 hindsight and 2021 foresight. So what are we going to talk about? Why this webinar? Basically, we decided to have this webinar, A, which we haven't seen you for 15 months, since it has been 15 months since the pandemic was declared, and over 6 months since we saw many of you. So it was time to say hello. So, hello everyone. Much has changed, and we have become a bit wiser, maybe a bit more aware of this virus and its behavior and how we can protect ourselves and our business. So we wanted to share what type of COVID-related project we have been involved in. Briefly saying, what have we been doing for the last 1 year? Uh, we realize that this is a world pandemic, not only hitting us here in Ontario or in Canada or North America. It's a world pandemic. We have to not only put our house in order, but also to walk in their shoes, in the shoes of the other people, and above all, learn from their experiences. And with that, help you, our clients, manage your workplaces and keep your employees healthy and safe. The protocols and the procedures that were recommended a few months ago are no longer as important in light of the new variants and the new accepted role of aerosols in the infection transmission. So, can we just sit back and do nothing? No. Inaction is really not an option, and we cannot and should not wait for the regulatory compliance to order us to act. We will pay a very heavy price in terms of human suffering and economic loss, as some of the countries have and are paying. Each one of us has a role to play, both as individuals, for example, by getting vaccinated, following public health guidance, etc., as well as corporations, for example, by adding screening protocols. The science and the knowledge about the virus is changing so fast that we feel it's important for us to share with you what we know so that together we can update your risk assessment and your risk managing plans in light of emerging knowledge. We know we as business cannot afford more lockdowns and restrictions. We cannot afford our workers to be not fully productive. We cannot afford to lose our workers. We want to familiarize you with some of the jargon around the vaccine, the screening tests, etc. In short, we organized this webinar primarily to update you and let you know what we at ECHO have done since the start of the pandemic, the lessons we have learned, and where we are at and where, in our opinion, we should be heading. And that's our foresight. That basically summarizes what I am going to say in the next 10 minutes or so. Next slide, please. Now, in terms of what have we been doing, we can classify that uh, group into three categories. We had some interesting projects that we were forced to think outside the box and outside our own comfort zone. For example, one of those interesting projects involved assessing and comparing COVID risk while flying commercial airlines versus small chartered aircraft when a party of 10 or 15 people were expected to fly together. Results were astounding and quite different than what we had initially thought before we took the project on. Similarly, we were asked to evaluate COVID risk to the drivers of public transport buses. Once again, it's not something that we do every day, but that's where we brought in our expertise to do research and put our hygiene principles into play and provided the advice on that. We have been assessing ventilation in several high occupancy and unique occupational settings and have designed appropriate interim measures as well as advise them long-term permanent solutions. We have been quite active in several advocacy initiatives that included arguing slash discussing with the public health agencies at the provincial and national and international levels. So suffice it to say, we have been busy, have learned that this last chapter on this virus and how to deal with it has not been written. So as I speak to you by the end of the webinar, I'm sure we will have some new knowledge that we don't know anything about. So staying constantly in touch is important. And that's the hindsight that we are dealing with. Next slide, please. So how much has changed? Where are we at? The original purpose of the lockdowns and stay at home orders to flatten the curve, to consider the lockdown as a management tool, not to overwhelm the healthcare infrastructure, has not changed. So that has not changed, but our perception has. Collectively, we fail to recognize that lifting the restrictions is once again a balancing act to find a balance between lives and livelihood. Lockdowns do not kill or eliminate the virus. They only restrict the number of hosts for it to infect, replicate, and spread. Unfortunately, those hosts are us as humans. Many of the workplaces where the virus finds us to attack, replicate, and mutate are our workplaces. Some of these mutations, known as the variants, as we will learn a little later, are more infective, more transmissive, and more deadly. So I want to look at this issue, um, first of all, globally, and then how are the situation here at home. Next slide, please. This slide shows you the global spread as well as the intensity of vaccine, in the intensity of the spread of the disease. The darker color shows the higher rate of infection in those countries. Global spread and the intensity of the disease spread is really frightening. I'm sure most, if not all of you, have seen or read about the havoc this pandemic is unleashing in India. The horrific pictures are really heart wrenching. And I say, how did this happen after more than 1 year after the start of this pandemic? What did they do, or more precisely, what they didn't? And then the question is, I am not here to talk about what India and Indians did or didn't do, but I bring that up and want to know is how different or similar is the situation here in our own backyard. Look at the color in Canada versus the color that shows the rate of infection. Not too different here. So, are there lessons to be learned from the tragedy unfolding in India? The tragedy that unfolded in New York a few months ago, or the tragedy that struck in California earlier this year, where the ambulances would not even take you to the hospital if they assessed your chances of survival were low. Let us put things in perspective. India's population is 100 times that of Ontario. So when we see 3,500 cases in Ontario, they translate to 350,000 cases in India. So the disease spread in Canada and particularly in Ontario and Toronto is similar to that in India. But what's the difference? Next slide, please. The difference is that we have more health capacity. As this slide shows, we in Ontario have 5 times the hospital capacity compared to that of India. Even though Ontario with 2.5 beds per 1,000 people is the lowest in Canada amongst when we compare it amongst other provinces. Even with this capacity, our healthcare system is very stretched and our ICUs are at about full capacity. And that's why we are here in a virtual lockdown. And this lockdown, which is supposed to end on May 19th, there is now talk of extending it by another 2 weeks to make sure that our healthcare system does not crumble as it has in some of the other parts of the world. As you can see in this slide, we are in the third wave of the pandemic. It's clear that this virus is really mutating rather rapidly and spreads far and wide rather quickly. The mutated virus, commonly referred to as the variants, and when the variants are more infective and are more deadly, they are categorized as variants of concern. Look at this slide. The third wave variants account for 90% of the infected of the tested cases. They are not the original virus, but the variants. And most of those, 90% of the variants, are the UK variant called the B117, which is 60% more contagious. And some reports indicate that they are 67% more deadly. Similarly, you look at India's variant, B6172 appears to be spreading very more quickly and has been identified in some of the Ontario samples. So we are a part of the global community, and whatever happens in any other part of the world, it is going to happen to us sooner or later. Next slide, please. So, what is the foresight? Where are we headed? I think there are three areas we are working or seeing our 2021 foresight. First of all, trying to eliminate or significantly reduce the hosts, reduce the possibility of infections at work, and reduce the viral exposure or the concentration. It seems the whole world is depending on vaccine as some sort of a semi-permanent solution. In Ontario, we suffered from both the availability and to some degree on the hesitancy of vaccine, such that until last week, we had only 3% of the Ontarians were fully vaccinated. Just an aside, India had 2% of its population of 1.3 billion fully vaccinated. Availability, because we do not, the biggest reason that we have only 10% or 15% of our population vaccinated here is the issue of availability. And availability because we do not produce any of the vaccine in Ontario or in Canada for that matter. And we had to depend on other countries. Vaccine hesitancy has been caused by lack of understanding of many of the technical jargon that has been thrown around for us. The University of WhatsApp has been very active and has been giving information that we are all become experts on without completely understanding on it. Marianne, my colleague, will deal with the various aspects of vaccines, their efficacy, the reasons for the hesitancy, etc., in a little bit more detail after I finish talking. Until most of us are vaccinated, and even beyond, a strategy to carry out screening at workplaces may be a useful step for identifying asymptomatic and pre-symptomatic people, keeping them out of the workplace and thus reducing the possibility of inadvertent spread of disease. Marianne will discuss the rapid tests and the workplace testing strategies that can be used with advantage. We, as industrial hygienists, always felt that aerosol transmission must be playing a role in the spread of the virus. However, the infectious disease specialists who are more familiar with the spread of infectious disease in a healthcare setting, and consequently our public health agencies, including WHO and CDC, emphasize the importance of droplets and fomites as the dominant transmission routes at the start of the pandemic. It has taken a lot of advocacy work, a lot of painstaking experiments in different universities and different workplaces to prove that aerosol transmission of the disease is a significant and a significant factor in the transmission of the disease. Therefore, ventilation and other dilution techniques were of paramount importance. Going forward, we hope to see a need for upgrading existing HVA systems in many of the workplaces. Rob Fernandez, the third speaker, will present some of the significant indoor modeling techniques and present recommendations for appropriate and adequate ventilation. Next slide, please. So, what does it mean for you? I think the important message is to consider whether you should update your risk assessment and COVID-19 prevention plan to take account of more transmissible variants, vaccination, testing, screening opportunities, and need to improve ventilation. And that is to familiarize with you with the current thinking on all of these aspects. We have brought this webinar for you. And I think, as always, I have taken more time than was allocated to me, so I better stop and invite my esteemed colleague, Marianne, to talk about workplace screening and testing and about the vaccines. Marianne, please take it away.
Well, thank you very much, Om. And as Om said, I'm going to be talking about vaccines and testing, and a little bit about transmission. So let's begin kind of with first principles. A lot of us here are health and safety professionals, and so we're very familiar with the concept of hierarchy of controls. And the most important element in that hierarchy is elimination. How does that apply to COVID-19? Well, we can't eliminate the people, although by closing workplaces, that's kind of what we've done. But if our workplaces are open, I think a first principle for us is to make sure that people who are infected don't come into the workplace. And how is that done? Well, we're all familiar with the screening techniques that almost all of our workplaces have been using over the last year, asking people about symptoms, sometimes measuring temperatures, asking if they've been traveling or exposed to anyone. But there is a new opportunity now with rapid antigen testing, which I'll talk about it in a minute, that is being rolled out in a major way now by the governments of Canada and Ontario. Going along with this, allowing employees to take sick leave, not just if they're sick, but if they might have been exposed or waiting for a test, is very important to make sure that people who might have the virus don't come to work. So two important measures with respect to elimination of the disease from your workplace. So what are we talking about when we talk about screening and testing? Well, we need to continue with our usual screening practices, the asking people about symptoms, etc. But as I mentioned, the government is rolling out new opportunities for rapid antigen testing or screening. Now, I presented about this last August when it had not been rolled out yet in Canada, but at that time I talked a lot about the principles and how this works. So I'm not going to repeat myself. If you want to see that presentation, we can send you the video of that and I can send you the slides. But in a nutshell, what I talked about then was there's kind of different kinds of tests. What we call PCR tests, polymerase chain reaction tests, are considered the gold standard for diagnosing SARS-CoV-2, the COVID-19 virus. That's used if somebody has symptoms or we think they've been exposed. It's highly sensitive and specific. That means there are a few false positives or false negatives with those tests. There are downsides, however, they're expensive. Often there's a long wait time for results. So they're not used all that widely. What's being rolled out now is called rapid antigen tests. Now that acronym stands for RAT. We don't like to use the word rat, so somebody came up with calling them rapid antigen detection tests, or RAD, a better acronym for that. Now they detect the protein on the virus, whereas PCR detects the actual genetic material or the RNA. They're less sensitive and specific, so they get more false positives and false negatives. But they can be very, as the name says, rapid. You can get results in 15 minutes without going to a lab. So the ones that are being used now actually show they have a strip that shows a line if you're positive. So it shows one line for control and the second line if you test positive. So they're used for just what it says, screening, to determine if perhaps you might be infected. And what's being done now in many workplaces is giving all employees these tests maybe twice a week is maybe an optimum number of times per week. So there's a lot of, it's very kind of risky in a way to rely on these tests as a definite, you're okay, but used in conjunction with other control measures, they can be very helpful in making sure that no one with COVID is coming into your workplace. And why is this important? Well, because we know that COVID-19 is largely transmitted through asymptomatic or pre-symptomatic people. That is, you can be very infectious about 2 days before you actually get symptoms. So if we were only screening for symptoms, we might miss all those people who are kind of harboring the disease but don't feel sick yet. So this can really help us identify those people without symptoms who might bring the virus into your workplace and infect a lot of people. And we know that now, especially with the lockdown, a lot of the continuing transmission is being driven by workplace outbreaks, where somebody comes in, infects a lot of people in a workplace who in turn bring it home to people that they live with. So controlling workplace outbreaks is extremely important right now. And these rapid antigen tests can be a way of doing that. So what is happening now? Well, both the governments of Ontario and Canada have programs for workplaces that want to run their own testing. It's now just in the last few days, the tests are being made available by the federal government to small businesses through chambers of commerce and pharmacies. The provincial program prioritized workplaces in high priority sectors, but as I said, the federal government now is making it much more widely available. These screening tests are free, but the employer does bear the cost of running the program, and there are costs to running the program, most notably staff time. Here's a picture here of one of these testing devices. And it's it takes a certain amount of familiarity and training to actually administer the test and run the program. So it's not sort of totally without a resource demand from the employers, but many employers are finding it worth doing. And you have to agree to some requirements from the government. If you do decide to get these tests, you have to record the data, you have to report, especially report positive results. The tests must be administered by a trained person, but one big change recently is that person does not have to be a registered healthcare professional. So it is possible to train someone without a huge amount of time, to train one of your staff, or to get some other assistance for somebody who can administer these tests. So the key things to remember about the rapid antigen testing: it's quicker and cheaper than PCR. It should not be used for diagnosis. It's only for screening. If somebody screens positive, then you have to very quickly arrange for a PCR test to see if in fact it was a false negative or a false positive. You must not relax any other preventive measures. I think one of the reasons people were hesitant about using this is they thought, well, people will just rely on this and then they'd stop doing everything else. No, it can't be used that way. All the other preventive measures we use have to continue if you are using these tests. But it does help to ensure that no one with COVID-19 will come into your workplace. You also have to follow the government guidelines. And very important, sick leave, whether you use these tests or not, are extremely important for anybody who tests positive, who has symptoms, who must isolate or quarantine because they in turn were exposed. If they test positive with these rapid tests, they should be able to have sick leave while they get a confirmatory test. So those are some of the key things to remember if you're interested in this rapid antigen program, which, as I said, is now quite widely available in Ontario. So I'm going to jump to another topic right now, which is vaccines. As Om said, the vaccine, right now we're rolling out vaccines to pretty much many people who want it, and the eligibility is expanding greatly. But after we do that, we might find, as they're finding in the US right now, that vaccine hesitancy may become a bigger problem than it has been up to now. And what can you do about that? Well, I think an important thing that employers can do is to educate staff to reduce confusion or misperceptions about the vaccine. So to do that, we might want to understand a little bit more about what vaccine efficacy means, about the many discussions we've been having about vaccine side effects, and some of the risk-benefit considerations with respect to vaccines. So here's this little quiz about vaccine efficacy. I'm going to just try to explain this fairly quickly because I do think that many of us don't really have necessarily an understanding of what it means when you hear these numbers from the government or in the media about the efficacy of a vaccine. So this isn't a test. I'm not going to grade you, but just think yourself, what's the answer to this question? Is this true or false? If a vaccine has 75% efficacy, it means that people who are vaccinated with it still have a 25% chance of getting the disease. So is that true or false? Just think about your answer. And the answer is that's false. Because what that term means is, it means that when the vaccine was tested, that when it was in clinical trials, vaccinated people were 75% less likely to get the disease than the people in the placebo group. And I'm going to show you in a minute that does not mean that they have 25% chance of getting the disease. So why? Well, here's a slide that sort of gives you an example of how efficacy might be calculated. I want to stress these are hypothetical numbers that I'm using just for the purposes of illustration. So imagine that you were doing a test and you had 100 people in the vaccinated group and 100 people in your control group who had placebo. Of course, when they do tests, many more people are used than that, but this is just to show you percentages. So of the 100 people in the vaccinated group, 10 got the disease. In other words, only 10% got the disease, but 40 people in the placebo group got the disease. So to determine the efficacy, you subtract 10 from 40, and what you get there is 75%. So that's where that number 75% efficacy comes from. So it sounds like 25% would get the disease, but in fact, in this example, only 10% got the disease. So again, if you get a vaccine and they say the efficacy is 80%, it doesn't mean you have a 20% chance of getting the disease. You're probably much less likely to get it than that. The other thing to remember is when they did these trials, they based the efficacy numbers on those who have symptoms of the disease. So it didn't measure the people who had the asymptomatic infections or were able to transmit it all. It also wasn't based on the people who got seriously sick, like who had to go to the hospital or who died. And what we're learning is that the vaccines are even more effective than the reported efficacy numbers in preventing the serious disease, hospitalizations, and deaths. So it may be important for your staff to learn that they may be much better protected if they get vaccinated than the numbers that are bandied about might suggest. So what's the status of vaccination in Ontario right now? This is changing so quickly, it's probably outdated between when I prepared this slide, which was this morning, and now. But as of this morning, or at least as of reported this morning, we almost had 40% of people in Ontario who had received at least one dose of the vaccine, of any vaccine that's been given out. The Ontario government is very quickly expanding criteria and age groups. So within a few weeks, we probably will have pretty much everyone over 18 eligible to get the first dose. The province is targeting 50% of vaccines to what they call hotspot communities, that is where the incidence of COVID is much higher. And they're rolling out in many different ways, mass vaccination clinics, hospitals, etc. Some large employers can host clinics, and there's ways to approach the government and find out if your own employer can host a clinic on site. And one interesting development is that the Pfizer vaccine has now been approved by Health Canada for children over 12 years old. Now, it's been given in Alberta, not yet in Ontario, but that may come soon. Addition, just of today or yesterday, the province announced that they're now making second doses available to healthcare workers and other high priority groups. So things are changing very quickly. And we do really want everybody who can possibly get vaccinated to do so. I'll explain a little bit why in another slide. So this chart is from the Ontario Science Table. And this is, they showed here the benefits of targeting the hotspot communities. And what this shows is the blue bars compared to the orange bars show how much benefit you get in terms of reducing hospitalizations, ICU admissions, and deaths if you target 50% of your vaccines to the hotspot communities. So the Ontario government did look at this data, And that's why we see those priorities being given to the hotspot communities for now. But as I said, pretty soon it's going to be available to pretty much everyone over 18 or maybe even over 12. Now, the other thing that's kind of unique to Canada is that we have a very long period between when they're giving the first dose and when they're giving the second dose. And why? There have been a lot of complaints about this, but this is also based on some good data that came out of the National Advisory Committee on Immunization, or NACI. And they said that a 16-week interval, which is what we have now, was projected to have the largest reductions in severe outcomes. In other words, use the available vaccines because there's a shortage to vaccinate as many people as possible with that first dose before you start giving second doses. And as I said, their modeling shows that this is the best way to get the best benefit for the largest number of people by using that strategy. There's also increasing data that the protection from the first dose is pretty good, and that it really is not been a decrease in immunity by extending that interval to 16 weeks. So, so I know you've heard a lot about AstraZeneca and the Johnson & Johnson vaccines, and I'm not going to have time to go into all the details about this, but I know the information has been somewhat distressing and somewhat confusing. You probably know that there's been incidents of a fairly rare type of blood clot, not an ordinary blood clot, but a rare kind of one that's now abbreviated VIT. I have what it stands for there. It's occurred in Canada and other countries with the AstraZeneca vaccine, and in the US with the Johnson & Johnson vaccine. Now, we've learned a lot about VIT just since this started happening. Now, healthcare providers know a lot more about what to look for. People who are vaccinated with these vaccines are given the instructions of symptoms to be on the lookout for. There's now guidance and on diagnosis and treatment. So just by virtue of doing those things, it's less risky than before we knew about this. So AstraZeneca is still given in Ontario to people who are over 40. And that committee, NACI, that I mentioned before, did some pretty good analysis of the risk benefit by age group. In other words, the benefits of getting vaccinated compared to the risk of getting VIT is not the same for everyone. It varies by age group. And essentially what they came up with is saying that risk benefit generally favors vaccination for people over 30. And this is just some numbers I pulled for the whole population, not specific to age groups. The risk of VIT is about 1 in 100,000 vaccinated people. Whereas the risk of COVID for all age groups in Canada right now is 65 in 100,000. So I think that you can see from these numbers, you're still at much greater risk if you don't get vaccinated than if you do, if AstraZeneca or J&J are the available vaccine to you. Things are changing a lot now because of different availabilities of vaccine. And just this morning, we read that Ontario is now considering administering second doses to people vaccinated with AstraZeneca using Pfizer and Moderna for the second dose. So things change so quickly. As I said, if I were giving this presentation tomorrow, I might have different information for you. But I think the main message is, given the high incidence of COVID in Ontario, if AstraZeneca is the vaccine that's available, the risk benefit will often favor getting vaccinated. But because of the availability of others, things may be changing very quickly. And why should we overcome vaccine hesitancy? Why is vaccination so important? Well, only high vaccination rates will let us get back to something that looks like normal and lift some of the restrictions we've all been living with. So this is a slide from the Public Health Agency of Canada. And it shows that what will happen if vaccination rate is fairly low. So the slide on the right is if only 55% of adults get a first vaccine dose. When restrictions are lifted, which is this blue vertical line, we may see numbers go way up. And the red dotted line here is the capacity of the healthcare system. So the worry is if we don't have enough people vaccinated, If we lift the restrictions, we're going to get back in the situation we kind of were in a week or so ago, where we're on the verge of exceeding the healthcare capacity to treat people. Whereas if on the slide on the left, if the first dose vaccine uptake is 75%, then we'll be able to keep the numbers below the level at which the healthcare system can deal with them. So what is this telling us? It's telling us that we need to get vaccinated, not just for ourselves, not just to protect our family, but for all of society, to help the whole society get back to something resembling normal. Now, what should change after vaccination? The public health agencies have not changed their advice about what people should be doing with respect to protection after vaccination. So for now, they're saying continue to observe precautions, including things like distancing and masks. And what's the reason for this? Well, we don't really know how well vaccination protects against infection and transmissibility. As I mentioned, we know more about how it protects against getting symptomatic disease and serious disease. As well, there's what they call breakthrough infections. We know that vaccines are not 100% effective and people can still get COVID. So until we have more real life data and we drive down those overall societal numbers, it's better to keep observing those precautions. Okay, I'm going to switch topics here again. The question is, what's new in our understanding of transmission? Mentioned that the kind of emphasis now is less on fomites, that is contamination of surfaces and objects. So we were so worried about at the beginning. It's not that it can't possibly be transmitted that way, it's just that we think it's less important. There's certainly been more emphasis on aerosol transmission lately. Now, ECHO presented on this in October. We have been emphasizing aerosol transmission pretty much since the pandemic started. But what's changed is that it's much more widely recognized now. And we've seen change statements and guidance from the Public Health Agency of Canada and the US CDC and WHO. Sorry about that. So what does this mean for us? Well, a lot of it is that we're going to have to think a lot more about ventilation. We know that transmission is 20 times more likely indoors than outdoors and that's because of the difference in ventilation outdoors. It also emphasizes that masks, that is preventing people from emitting those aerosols, becomes even more important. And as a result, there's been new advice from the US and from Public Health Agency of Canada. I'm not going to take time to go into that now. But there is some very good advice on the US CDC website and studies they've done on mask hacks, you might call it, including double masking and like hacks you can do to those procedural or surgical masks that actually make them fit much, much better. And it may be that with the increasing availability of respiratory protection, like what we call N95s or similar filtering face piece respirators, that we may, in some situations, need to look at those to protect people from airborne virus. And then, of course, there's the importance of ventilation, which leads me to a presentation by my colleague, Rob Fernandez. So over to you, Rob.
Thank you, Marianne. So as Marianne mentioned, there's increasing awareness, acknowledgement of aerosol transmission, and by association, ventilation becomes very important. So that's what we're going to talk about now. So other things we want to consider too, a couple concepts. What's appropriate ventilation? And what I mean by appropriate is what is the current best practice, best guidance available in terms of ventilation as it pertains to dealing with aerosol transmission, as opposed to just standard building code requirements, things like that normally we've done in the past may not be enough, and it really isn't enough going forward to deal with pandemics and trying to mitigate against those conditions. As far as adequacy goes, so when we talk about appropriate guidelines, the adequacy evaluation comes down to looking at your building and seeing how far off are you from the current best guidance that's out there. and see what the system can provide, what can be changed, what can be improved, and how close can you get to the guidance that we're going to talk about. So talk about ventilation, the hindsight 2020, back at the time it started, as Marianne mentioned, a lot of the public health agencies, including Public Health Ontario, put very little emphasis on air, as I mentioned. Is a very just small acknowledgement of it at the time, and at that time as well, a lot of the current or the advice for ventilation was pretty generic in nature, general, increase fresh air as much as possible, things like that. But there was nothing really quantifiable that you could try to evaluate your own site conditions, trying to see what you can do. At that time, there was guidance from ASHRAE talking about, putting in MERV 13 filters or better. So that was an actual tangible thing you could kind of cling to and maybe look into to improving your building. But other than that, there wasn't too much on as far as ventilation rates go. Fast forward to 2021, public health and other organizations have, looked at the importance and acknowledged the importance of both aerosol transmission as well as ventilation to control aerosol transmission. So that's good news, and it gives us a little more emphasis to kind of look at ventilation and try to improve that. Another thing that's come since 2020 as well, 2021, is that there's now that guidance comes actual numbers that we can kind of use to kind of guide, what's acceptable ventilation. So things like air changes per hour being specified, rates per person are being specified for ventilation. For example, you're looking at anywhere between 4.5 to 6 air changes per hour being recognized by different organizations as kind of a target minimum ventilation rate. And I would say accurate recommendation is, the higher the better. So if you can get to 6 air changes per hour or better, that's really what we should try to target if at all possible. But anything about 4.5 and above is going to be helpful as well. So look at ventilation, basically, at a very basic level, if you have a high occupancy space and poor ventilation, that's going to be a bad combination that might, certainly help with transmission of the virus throughout the between individuals. So that's a situation you want to avoid as much as possible, both the occupancy as well as the poor ventilation. So ventilation does dilute, all contaminants, not just a virus, but anything, dust, CO2, anything that's in the air. Ventilation is the intended is to reduce that contaminant level as much as possible and remove them through things like exhaust systems. When we talk about switching to 100% fresh air and minimize the circulation as per the 2020 guidance, that's all well and good, but you don't know how much you're really getting. So 100% fresh air can be a little bit misleading. For example, if you say your system has a 100% fresh air supply, but there's a large return component that's mixed in with that, you're not really getting 100% fresh air. And that's the bad thing, but return ventilation can be an important aspect of your ventilation operation. It's just a matter of being aware of what that it means in terms of overall ventilation rates and looking at which we'll talk about. Things like opening a window, obviously not every building has advanced HVAC systems. Some buildings are pretty basic. All you have is basically the option to open a window, and that does help. So opening windows does hopefully bring in more air. But again, it's hard to quantify, and I certainly won't want to rely on just opening a window here or there. You might want to supplement that with the use of maybe something like an exhaust fan to help push the air through the space. Because opening a window, you need something to drive the air into the room, either by opening a door across from the windows, or again, using exhaust fans installed somewhere else in that window bank to help move the air through the room and really get that air exchange rate up to where you want it to be. Airflow direction is also very important. So you also don't want to be blowing air from a potential asymptomatic individual that's could be potentially passing virus to other people via the HVAC or the airflow in a room. So if you look at the diagram here, I was going to bring my arrow up here, you can see you have the air supply coming in this room here, it goes down, and it goes back up to the return. The way that people are oriented here in this kind of desk area or this table area, if this person was symptomatic here, the airflow would kind of carry the virus potentially across before it goes up to the return. If this area orientation of workers was turned 90 degrees, they would actually only pass the one person at a time as opposed to all 4 in a row. So things like that, or look at your orientation of your diffusers and your ventilation system, which are sometimes easy to modify, or just changing the layout of your workspace to kind of minimize this scenario. That all help with reducing the risk of transmission of the virus between individuals. Similarly, you don't want to use directional air fans. So if you want to get more airflow in a room and you're using pedestal fans, for example, that can be a useful tool, but you don't want to be directing airflow from one person to people in behind them directly. You want it to be more of an indirect mixing of air that will help reduce the overall levels as opposed to directing it from one person to another. Another important concept too is the idea of negative pressure. So if you have a very high occupancy, part of your building, maybe a public space or a lobby or elevator lobbies, washroom, maybe people are congregating, lunchrooms, is to have the airflow kind of under negative pressure to kind of draw the air towards where the people are congregating, so that doesn't impact people that are in adjacent office spaces or less occupied spaces. So always want to go from dirtiest to cleanest, which is basically from high occupancy to low in terms of airflow direction. If you have exhaust systems in your building, make sure that they're operating operating correctly. But also, if there's any way to increasing that flow or increasing the fan speed or anything like that, try to do so. Right, the more exhaust you have in your building, the more air changes overall you're gonna get in the building just from exhausting that air out of the building and drawing fresh air from any cracks in the exterior envelope, windows open, doors, all those things will help draw that air and exchange the air in the room. And then lastly, just if your system has any kind of adaptable in terms of operating schedule, you definitely want to extend as long as you can. So ideally, 24/7, but at the very least, you want HVAC to come on maybe a couple hours before people are coming into work and a couple hours after to help flush the building out. So if there's any residual aerosols, you're kind of helping you reduce it as much as you can. The thing you want to do too is, like I said before, is you want to look at the orientation of your return supply diffusers. Now, supply diffusers sometimes are kind of in a fixed location, but returns, which is this kind of thing right here by the door here, the little kind of grate you see in the ceilings in a lot of office spaces, for example. This is your return. This is very easy to move. It's just a little grill. It's not connected to anything. It's just opening the ceiling, and you move that around to help control where you want the airflow to go in a room. And it doesn't affect the overall airflow. It just helps the direction more than anything. So if you look at this example here, this is actually an ideal location because it's above a doorway. So if any aerosols come from this adjacent to kitchenette area or the hallway, when it comes into the room, it would go up as opposed to further to room where the person are actually seated. So that's kind of a good little easy thing that you can do to kind of help with aerosol kind of direction in a space. Obviously, the door itself is also a very good barrier, so if you keep your doors closed as much as possible, especially as people congregating outside your door, also a good thing to be doing to kind of help block the flow of aerosols into the room. Another thing we talk about too is filtration. Again, the MERV 13, you want to be at that MERV 13 or better. Now that's subject to system capacity. Not every system can handle MERV 13. It might be too much of a pressure drop. So talk to your building technicians, talk to engineering that's helping you maybe with a redesign, and see what the system can handle in terms of increased filtration. But whatever you can do to improve to MERV 13 or better, that's what you should be targeting as much as possible. And the filter is only as good as how well it's installed. So if you install it filtered correctly, if there's gaps or this filter gets damaged when you try to shove it into the unit, that's going to compromise the filtration. So make sure that once it's installed, that there's no gaps, there's no damage to the filters. That way, the filtration is actually what it's intended to be, which is full filtration. And then lastly, another thing that's come through the guidance right from the beginning, actually, that's one thing that hasn't changed really too much since 2020, is the idea of keeping relative humidity around the 40 to 60% range, as opposed to having it too dry where you get more potential for people to get illnesses. So that's also a thing to keep in mind too, is try to target 40 plus. So obviously it's gonna be hard in the wintertime, but in the summertime, it's easy to do. Just having let more airflow come from outside, it's already kind of humid anyways, and that'll keep up your humidity kind of in that upper range there. So ventilation and circulated air, again, a lot of older buildings may not have that much, ventilation to begin with. But even newer buildings that have, newer systems, they still will have capacity limitations because they're designed to kind of heat and cool potentially extreme temperatures outdoors, right? Dead of winter or really hot summer. So you cannot necessarily always have 100% fresh air from that perspective, because otherwise you'll have very uncomfortable environments in the building in terms of either being too cold or too hot and humid. And recirculation, again, is not a bad thing. As long as you have enough filtration of the air that is being recirculated, then you should still be fine. It's just a matter of knowing what that filtration is and the overall airflows that you're getting and exchange rates in the space. Just to give a kind of point of reference, something that's easily done is you can measure carbon dioxide levels, which act as a bit of a surrogate for overall air quality and air exchange in a space. And that's because the outdoor levels of CO2 are typically in the 300 to 400 range in most places. And so by knowing that, you compare it to your indoor environment, if you're close to that number, or very as close as you can get to that number, then you have a pretty good, essentially you have outdoor air in your space by default. And that's what you want to aim for to keep the levels low. The issue with that, especially currently where we still have occupancy restrictions in buildings and people are, still under lockdown, is that measuring it now when it's low occupancy can give you a bit of a false sense of security, because you will get more than likely low numbers. But it's a useful tool when you do have normal occupancy to kind of track the CO2 and see how it changes. If it builds up a lot over the given day, or it changes one day to the next with the same occupancy, it'll point to an issue with your HVAC that needs to be looked at. So it is a bit of a red flag scenario when it does jump all of a sudden, or if it builds up over time. Another thing to remember too is that our carbon dioxide typically comes from exhaled breath in the building. So, for example, if you have 1,000 ppm measured in your space, that basically roughly means that you have about 2% of air that's being breathed in from someone else. So you're basically breathing in someone else's air, which if they're carrying COVID, is going to be potentially an issue. And the other thing you want to keep in mind too is that, fresh air is no longer fresh once it gets into a room. So you have fresh air from outside, 100% fresh air, whatever the case may be. Once it enters your unoccupied space, it stops being fresh air because now you have people breathing into that same air and mixing it, and it's no longer fresh air. So that's why the idea of air exchange, more than anything, is very important, as opposed to just relying on fresh air kind of necessary concept. So when we look at HVAC systems, it's not always easy to say, oh, I'm just going to switch with the HVAC system. Obviously, it's usually a big undertaking in a lot of buildings. It's it takes a lot of time, takes a lot of effort, a lot of it's financial commitment as well. So what can be done in the interim is the use of what we call portable air cleaners. They're kind of a good alternative to kind of as a stopgap measure to help you deal with with potentially having to keep an area occupied, but also providing enough control of the aerosols in the space. And what these units do essentially is they filter the air in a localized environment. They're basically almost like a scrubbing unit. They typically have HEPA filters, which are very good at removing aerosols, including the virus. The other benefits that these units have, they're easy to install. They're kind of plug and play for the most part. They help move the airflow around the room in general. They basically really just supplement what existing HVAC you have in the space to help improve it overall. They also come in very handy for things like isolation rooms in healthcare facilities or long-term care, where you just roll it into a room, you plug it into the window, you direct it towards the patient, and you're basically pulling all the air from the patient through the unit and outside through the filter, so that's not impacting the staff in the building or other occupants. So it is handy for that purpose as well. On the right-hand side, you just see decision matrix that came from School of Public Health from Harvard. Just basically tells you if you have an HVAC system, yes or no. If you don't, then you obviously open windows, things like that. If you do have a system, is it MERV 13 or not? If no, then you kind of go to the PAC. So you just kind of follow that decision matrix to figure out if you need PACs or not. If you are going to get PACs, then you want to also make sure that you know what the cleaner delivery rate is. This basically tells you how much airflow, filtered airflow, is the unit providing for you, so that you can roughly calculate how much air changes you have per hour on that basis. So they took your room size of the room that you're dealing with, you look at the PAC capacity, and you basically do a bit of math, which is really easy to do, but we can definitely help you with that, to try to calculate what kind of airflow you need and then what units you'll need to kind of get to that airflow. Rule of thumb is basically if anything that doesn't provide at least 2-to-1 ratio increase over your existing air changes per hour, it's probably not worthwhile. So make sure that you're getting enough PACs that you're going to be at least a 2-to-1 increase over the existing ventilation in your space. And also the thing to keep in mind too is if you have a large room, you don't get one large PAC for the middle of the room. It's usually better to kind of spread them around a little bit and use smaller units to help promote air mixing throughout the entire room, as opposed to having it in one location. Just kind of keep that in mind as well. These units can be pretty noisy, especially the ones that have the higher flow tend to be a little bit noisier. So another thing to consider well is that if you especially have an area that needs to be quiet, for example, like a courtroom where you need to have it relatively quiet so you can hear people speak, or a lecture hall, for example, that you make sure that you're looking at the decibel ratings of the unit and maybe testing it out for a little bit before you commit to buying a whole bunch of them to see if it does work for you in terms of noise levels. These units also require service and periodic filter changes, so just keep that in mind. It's not just a matter of you plug it in, now it's good for the next 10 years. You do have to periodically check that the filter is not overloaded and that the unit's kind of being working properly. And then lastly, one thing to remember too is that this is not the magical solution to our aerosol problem. There is a lag time for filtration to actually work in a given space, whether it's from the HVAC or from these units. So you still have to do the physical distancing, still have to use the masks and everything else to help control the overall aerosol levels at the source where we're generating it, so that we're not relying on air changes per hour to catch up with what's happening in a room at any given time, right? So there's that lag to kind of consider as well. As far as trying to evaluate, what you have, it's a matter of reviewing, look at HVAC systems, see how much airflow you actually have. What is the fresh air component of that? What is your filtration available? What kind of shape is the filtration in? Is it installed correctly? So all these things you want to look at and try to evaluate, how good you are in terms of comparison to the current guidance that's available out there in terms of air changes per hour and things like that. So things like carbon dioxide can be used as a measure, like I said before, to measure as a surrogate measure of ventilation rates. For example, if you have a building that doesn't have any HVAC, you're just relying on open-wing windows, and you want to know how well the open-wing windows approach works for you, you can actually do what they call a carbon dioxide decay test, which is basically you set up the room, you put in dry ice, you get it to a certain concentration of ppm of carbon dioxide, with the room obviously being empty, and then you basically see how that level of CO2 drops over time based on, and you can calculate on that basis what your exchange is in a room. So even if you only have opening windows as an option, there's still a way to kind of evaluate whether or not you have enough air changes per hour, even on that basis. Also, you want to look at packs, make sure, again, as I said before, you have the right number of units and right size and rate for the space that you're trying to deal with. Make sure the placement's kind of appropriate as well. We can obviously help you with that and give you some guidance. Indoor quality measures, so again, carbon dioxide can be measured as well in real time. Relative humidity can be checked as well. Temperature, make sure that they're all kind of in that comfortable range. And with humidity, make sure that they're 40 to 60%. Airflow measurements. So again, I said before, airflow direction is an important concept to consider when you're looking at your HVAC, not just the overall ventilation rates. So that can be done with either smoke tubes or anemometers. You can measure the direction of the flow, how fast it's moving, get an idea of where things could end up. If an aerosol comes out of a person, where's it going to go? And that can be evaluated with testing as well. There's also currently testing that's been developed in the last little while for actual aerosol measurement that's actually a surrogate for the actual virus. So there's a company called, a process called Veridart, where they release a DNA containing aerosol from a given point, and then you do take samples at various points, both the origin as well as other rooms in the building, to see where that aerosol ends up. So it's another way of testing to see airflow direction and air exchange in a room. So how does ECHO help in improving air quality and ventilation? So what we can do is, and you can do it yourself as well, is talk to your facility managers, talk to your building technicians, and the landlord if you're in a leased space, and just ask the questions like, what is the existing ventilation rate? How much fresh air is coming in? How much ventilation am I getting, per square foot or the size of the room that you're in, to get an idea of how close you are to that, recommended air changes per hour that we talked about. That's ideally 6 or better air changes per hour. But you need the numbers. You need to know what's being provided. So ask those questions and verify it. We dealt with clients where they were told, 100% fresh air, we're 100% fresh air. And we went to the building and that wasn't the case. Their damper was open 100%. That is true. But they were operating on a 15% fresh air and 85% return air system. So there's a lot of return air. And luckily in that building that the MERV 13 is a MERV 15 filter, which is even better than MERV 13. So they were okay on that front, but it was still misinformation. So make sure that you're verifying it, ideally either with a third party or yourself, to make sure that the information you're getting is correct. And then it's a matter of, recommendations that are going to be developed. Make sure that you're customized to your building situation that you're dealing with. Every building's different, obviously. Occupancies are different. Use of the space is different. So make sure that you're looking at the whole picture as well and try to assess the risks there. As far as packs go, maybe talk to suppliers, talk to third parties, and try to see what is the best option in terms of trying to supplement your existing ventilation and seeing if it'll meet the kind of guidance that we talked about earlier. So as far as ventilation infection control foresight, so moving forward, things that you want to consider in your pandemic planning is now is the time, right? It's already been a year. Hopefully you've already started, but it doesn't hurt to deal with it even now. Look at your HVAC, look at your ventilation systems, and you really get the information, like I said before, of what's being provided, so they can make changes if necessary in the next little while before the pandemic is over, and then maybe pandemics come down the line. So while the buildings are empty now, currently, it's easy to kind of make some of these changes and do some testing, because building, there's no one in the building. It's easy. It's a good time to do it. And similarly, contractors are not quite as busy as they are, before the pandemic. So as far as any changes you want to implement, it's a good time to do it from that front as well, because people are going to probably give you better pricing, have better availability to move diffusers around, install new HVAC, and improve filtration, things like that. It's a good time to do so. If you're doing any kind of planned renovations or changes to HVAC, that's what you're thinking, then make sure you're not following just the building code or the minimum requirements, but really look at the current best guidelines and practices in terms of air changes per hour and things like that, and try to get to those numbers so that you're kind of prepared for any future pandemics as well. You're better placed to deal with it. Consider installing systems that are kind of also ideally have variable airflow. So basically don't commit to a certain speed of fan, and all of a sudden you need a higher flow down the road and I have to change everything. If you can get a variable speed fan, both on the supply side, on the return, on the exhaust systems, where you have a little bit of flexibility. That way, when the pandemic is over, you can kind of dial back all those flows to save, on the energy costs. But it's an easy matter of just increasing the flow when you need to. And that's really, that gives you some flexibility in the future if there's any future kind of pandemics to deal with. Consider also redistributing your system as well. So if you have any VAV boxes, which are variable flow boxes that can help control the airflow, take advantage of those, right? Look at your occupancy levels in parts of the building and maybe change them. Change it if you have occupancy space and a less occupied space. Change it. Now, if they're both 50-50 split, maybe do a 60-40 or look at changing it based on the occupancy that you're going to be anticipating in that space, so that you're getting the maximum kind of air changes based on the occupancy. It's also a good opportunity. Also, if you don't know your air changes are per hour and you do have an actual mechanical ventilation system, measure it. When you do a rebalance, you actually will get the actual flow numbers from each diffuser in the building, and you'll be able to total up, what the overall airflow is, and then you'll be able to say, okay, we're at 2 air changes per hour, we're at 3 air changes per hour, and it's a matter of maybe ideally increasing the flow if you can, but at the very least, you'll know what you're dealing with by doing that air balancing, see how much flow you actually have. Another thing you want to consider too, if you're doing any kind of changes to your HVAC and upgrading it, is installing sensors, things like carbon dioxide sensors that could provide continuous monitoring, real-time monitoring of your carbon dioxide levels. Like as we said before, that can help determine whether you have any ventilation problems in the building. So if you have the sensors in place and they operate 24/7, if you have a sudden change in CO2 levels like that, it can point to an actual problem in a given space, and it'll help you kind of identify problems much faster than if you just assume that everything was working correctly and you don't have any sensors. So it's a good thing to kind of invest in. The one caution, like I said before, is if it's an unoccupied space, it might not be that much useful information. Or if you combine multiple rooms together, it can also kind of not give you the whole picture. So it's ideally, if you're going to go down that road of sensors, ideally put them on each return for each room that's got significant occupancy. And then lastly, especially the last 10, 15 years, a lot of energy conservation measures have been put in place in buildings. And with that, we've got demand-based ventilation systems that only come on when there's people in the building or people in a room. And we also have a lot of energy recovery systems, things like HRVs, and that recover energy from the airflow that's being exhausted. And those are all good things from an energy perspective, but it can be necessarily a bad thing for dealing with aerosol control. So just make sure that if you're using demand-based systems, that they can be overridden. So basically, turned off or bypassed somehow, so that you do get maximum ventilation all the time when a building's occupied. And as far as energy recovery, make sure that the systems don't allow cross-contamination of return airflow that hasn't been filtered yet, and that could have aerosols in it, crossing back over into the supply side. So make sure the system's completely isolated if you do have any energy recovery systems. It's a little more foreshadowed as well. This is outside of just ventilation, just other things I want to mention here as well. If you don't have a pandemic plan in place, really consider putting it in writing, getting it formalized, so that use the latest public health guidance and maybe use consultants like ECHO as well to help guide you. But definitely you want to have something written that can also be easily updated for any kind of future pandemics or any future issues that we have to deal with. So just make sure you look into getting it in writing and get it a well-developed plan in place for your workplaces. Take advantage of technology that helps track occupancy. So things like online forms, electronic key fobs when you come through the door, various apps on phones, things like that can help you track. If you have occupancy restrictions that are in place by the public health agencies, it's a way for you to easily make sure that you're meeting those recommendations by having some sort of occupancy tracking in your building. If you modified your workplace to have more spacing for your employees, consider keeping that in place. Don't go back to the same old situation we had before. Because even during flu season, it's always good to have these measures in place as far as infection control goes. So make sure that if you can, keep the employees not facing each other, well spaced out as much as possible, maybe not the 6 feet, but as much as you can. Keep some of the barriers in place, especially for public-facing areas, reception areas, for example. Maybe keep those barriers in place, the plastic or the plexiglass kind of window there. It'll probably help with the future transmission of illnesses as well. If you install things like hand sanitizer stations, touchless faucets, things like that, any kind of signage as far as hygiene goes, keep them all in place. Don't get rid of them. If you haven't invested in some of these things, obviously maybe look into improving and investing in some of these items. If you are able to have dedicated entry and exit in a building, that'd be ideal as well. So people are not crossing paths, especially things like in stairwells, have that directional flow at all times. And if you have separate entrances for public versus employees, that will help too, as far as interacting with the public, as trying to keep that to a minimum as well. If you can at all possible, that would be good. Work from home policies, again, those are all things that you want to consider as well. And also rotating employees in and out of the building as required to keep that the occupancy at a lower level, if at all possible. And then lastly, another thing to consider is for future kind of pandemics, is kind of have a line on where you can get supplies from, especially things like PPE, masks, and that, face shields, respirators. Try to have a supplier that you can kind of go to when if next time around we're ready to go. But don't try to stockpile it, or at least if you are going to stockpile, be aware that things do expire. Things like rubber masks do expire. So don't go overboard and stockpile too much stuff, because it could expire before the next time you need it. So I think with that said, I think Om, I'm going to pass it on to you to kind of take over those last couple of slides there.
Thank you, Rob, and thank you, Marianne, for such excellent presentation. We have about 15 minutes left. Next slide, Chanel, please. So in summary, basically, you have to look at your own programs and see if you need to update your COVID risk assessment and response plan in light of the new variants, availability of vaccines, which is, as Marian said, changing every day, availability of the rapid tests as screening tests, and you need to consider your pandemic procedures, and most importantly, in terms of evaluating and upgrading your HVAC systems. So if I think I'm going to now open the floor for any questions, and Chanel, back to you, and you can direct the questions to whoever is appropriate. And
Awesome.
thank you everyone for attending. Thank you very much.
Okay, so the first question that we have is, can you comment on the accuracy of RAD, false positives or false negatives? And what is the approximate cost for parts and labor? And also, is there a shelf life for these screening test kits?
Yes, I can answer that.
Yeah.
Thank you, Chanel. Thank you to the questioner. Okay, so I'll deal with maybe the easier parts first. The cost. Right now, the governments are making these available for free to employers if they qualify. It is possible to run your own program if you're not considered to qualify and buy the tests. I think they're charging about $20 per test now. There's a volume discount. But with the increased like applicability or eligibility of employers who can get these, I think it would probably be easier and easier for employers to be able to get the test for free. That's for the tests themselves. There's still going to be cost to the employers in running a program, largely staff testing and time. So staff time to do the tests, obviously time for your employees to take the test. There might be kind of minor costs in just waste disposal, because the swabs that are used, the test strips, they would be considered biomedical waste, not hugely hazardous. I mean, not much more hazardous than, say, a tissue that was used, but they should be disposed of as biological waste, so maybe a little cost there. In terms of accuracy, there isn't a very simple answer to this, because the reason is they're mainly concerned about accuracy during the very contagious stage, like especially, as I say, pre-symptomatic or asymptomatic. So if you were comparing it to PCR, which can measure down to very low levels, say even after somebody might test positive in a PCR, even if they're no longer contagious, the comparable accuracy of the RAD tests would not be very good. But we're not really interested in knowing if somebody had COVID-19 and no longer contagious. We're interested in knowing whether they're contagious now. And with that criterion, the accuracy is really quite good. It's in the close to 90s for both the false, so only maybe 10% false positive or false negative. It may vary. It's good to look at the particular test that you're using. The one the Ontario government seems to be using most is called the PanBio test, which is made by Abbott. And it's reported to have extremely good sensitivity and specificity. But of course, it's not 100%, and hence all the qualifications that I mentioned before. Don't rely on this test to give you a free pass. You can go out and forget about all the precautions if you get a negative test. No, there still are some concerns and qualifications that it's not 100% accurate. And there was another part to the
life?
The shelf life.
Yes.
The shelf life is considered also very good. So right now, they're distributing test kits that they say will probably not expire until 2022. So it's not forever, but of course they're distributing ones now that the government would expect you to use very soon. So they're not going to give you a whole pile of them to stockpile for months and months. So they would give you enough to use over a few weeks, and they expect the shelf life to be quite good for that period of time.
Awesome. The next question we have is somebody mentioned how they came to know about a new technology to purify the indoor air using something called IVP, or integrated viral protection. Have you guys heard of it? Are you guys familiar? Do you have any comments on it?
I haven't heard of it, unfortunately. No, not that specific terminology.
No problem. And then the last question we have so far, is do you have any information or thoughts on mixing vaccines? Example for if you start with Pfizer and then you get AstraZeneca later.
I guess I'll take that one too. Well, actually, they're not really looking at Pfizer first and then AstraZeneca, but they are looking at AstraZeneca first and then Pfizer. And with that regard, it looks like the efficacy would be quite good, but we can't say that for sure yet. And that's why the government they've said they're considering it, but they are looking at a study, and apparently they have been doing this in a study in the UK, and they're looking at the results right now. But they are expecting it to be good. And as Rob said, I think you said, Rob, that essentially the whole purpose of vaccines is to kind of supercharge your immune system. So when your immune system sees the virus, it's going to react against it and attack it before it can make you sick or make you very sick. So given that they both do the same thing, they're expecting that another boost to your immune system would only be good. And that's the thinking about it right now. That's why they're considering kind of a mix and match approach.
Awesome. And then okay, we got one more. Do you foresee vaccine passports in our future? Any opinions? Good idea, bad idea? How are you guys feeling about it?
Okay, I don't know if any of my colleagues want to chime in on that one. It's certainly, yes, it's certainly being considered. The government is looking at it. Certainly they're looking at it in kind of more detail in the US. They're talking about, how would we know, how could you validate whether in fact you had got a vaccine? Should there be an app? Should people get little QR codes to show they've been vaccinated? There's talk about different countries requiring it, in which case it wouldn't be our government, it would be the country you wanted to visit. They might require proof of vaccination before you traveled, or the airlines may require it. So it's not like the government necessarily needs to require it, but the government may need to respond to say, we will provide some kind of indicator that you have been vaccinated. And there may be a demand on the government to do that because people will want to be able to provide this proof. So do I foresee it? Yeah, I think it's very likely there will be something like that.
If I can just add to what Marianne has said, how different is it than when we are going to certain countries in Africa that we have to show them that we have been vaccinated against yellow fever, we have been vaccinated against hepatitis. So many countries have different requirements of these vaccinations. So this is not a new concept. Back in the 70s and 80s, even if you visited many countries, you had to show that you had taken smallpox vaccination. So asking for, or if Canada imposes that as a condition of entry into Canada, it will be no different than what many of the African countries are doing.
Rob, any comments or?
No, I agree with what Marianne is saying. Yeah.
Awesome. Okay, and then two more. What are your recommendations for an office building that does not have windows that can be opened?
I'll answer that. So I would assume that has no windows. It must have a centralized HVAC system. I'd be shocked if it didn't. So if that's the case, you just want to find out what is the capacity of that system relative to how big your building or your space is, right? How much airflow you're getting from that unit. But I would expect that building that doesn't have any openable windows. It must have mechanical ventilation, and it's just a matter of finding out how much airflow is being provided by that system.
Awesome. Okay, we had somebody who asked, do you think COVID will become a seasonal thing? It seems to be better during warmer months. Any thoughts on that?
Yeah, I could comment on that. Owen might want to also. It does seem to be better during the seasonal months for two reasons. One is because we tend to do things outdoors more, and certainly, as like last year, I expect it will be this year, we'll probably choose to do most of our socializing outdoors. And as I mentioned before, the risk of transmission outdoors is about 20 times less than indoors. So for that reason, but also the virus seems to survive better in cold conditions. So yes, it certainly might tend to be worse in the fall, but and winter. Will it be a seasonal thing? I think it's very possible. Of course, nobody can predict the future, but I think some of the thinking now is that's very possible for a number of reasons. One is the variants, because we keep getting new mutations, so they may there need to be ongoing vaccinations, and they'll probably be developing vaccinations that are better against the new variant. So it's kind of like flu, that we may need, like we get a flu shot every year because to account for the new variants of the flu, it may be very similar to that with COVID. The other thing too is I think people are feeling like we may not get to herd immunity. You may have noticed we didn't really mention herd immunity in this presentation. And I think that's because people are feeling a little more pessimistic about totally knocking out the virus. And the thought was if we could vaccinate enough people, we would just knock it out through herd immunity. But the numbers that we are being talked about for getting to herd immunity keep going up. So like maybe, quite like north of 85%. And the way things seem to be going, we may not get there. So between the variants, the lack of herd immunity, it may mean that it is seasonal. And the hope is that somewhat like flu, the virulence of it, the lethality of the virus may decrease over time. So it may be something we end up living with like flu, but maybe not quite as deadly as what we're seeing now.
Awesome. We had a question for Om. So it said, Dr. Malik, can you share your results or findings of your work on airline safety?
I can just briefly mention that in that particular study that we did, as I said, it was surprising that at that time we felt that the chartered aircraft carrying 15 or 10 or 15 people party or the ventilation system, etc., they were at a higher risk of contracting COVID-19 than those who were flying the commercial airlines that were flying at that time. But beyond that, I can't say much, but that was surprising. We thought that, and everybody, when the project was given to us, their hope was that we will come back and we will say the chartered planes, private planes, they were a better option than flying commercial airline, but our study indicated otherwise. Marianne, you were the principal investigator in that.
Right.
Yeah. You may want to
Yeah,
add
well,
more.
that's kind of what we concluded. I mean, of course, it depends on many factors. I mean, such as what's the likelihood that somebody with COVID might be on your charter flight. And we did find that ventilation on commercial airlines is really quite good. So that they have HEPA filters, they have very high air exchange rate, very high percentage of fresh air coming in. So the risk of transmission on the flight was relatively low. I mean, not zero, but relatively low. Greater concern with flights, and this would apply to charter as well, the risk would be higher in all the things that you do before you get on the flight. So waiting around in the airport, standing in line to board, et cetera, was a higher risk. Even boarding the airplane, as you probably remember, if we can remember when we last flew, you're kind of standing in line with a lot of people very close while we're all putting our baggage up top. That's kind of, you can't really distance when you do that. So all those things were greater risk than actually sitting in your seat with the ventilation system on. So we had some tips as to how you might avoid those higher risk situations. But Om was right, that was kind of our conclusion, that actually flying on a commercial flight was relatively low risk.
Awesome. Okay, and we are on our last question. Again, so we only have 3 minutes left. So if you did have any questions that didn't get answered during the presentation, please feel free to reach out to us at info@echo.ca or learning@echo.ca, and we'll be able to get your questions directed to either any of the presenters or to anyone else on our staff who can help you. The last question that we have was, what are your thoughts on golf courses opening or scuba diving?
I think that's a question.
I'll answer about the golf courses. I don't know why they have closed the golf courses. Golf courses are low occupancy, outdoors, But of course, the people who are working at the golf courses, they are not. They have to clean the golf carts, so they are at some risk. They are the ones who are going after you to fix and get the golf course ready for the next day, registration, food items, etc. So individuals can look at it that as an individual golfer, you may not be at a risk, but the people working on the golf courses, they might be a close contact for them. And for that reason, the golf courses are kept closed, and I can understand that. I don't know much about the scuba diving. I don't know how the virus behaves inside the water, whether it drowns, it lives, it transmits in water or not. I haven't read too much about that.
Yeah, I think it's probably fairly low risk because you're getting a supply of air. So
Yeah.
presumably that's a clean supply of air.
Yeah.
So I would imagine scuba diving risks are very, very low. That is, once you're in the scuba diving, in the water. I mean, I think a lot of the concern is all the things that lead up to doing these activities. Just
Yeah.
as in a golf course, it's not walking around on the course, it's being in the, in proximity to other people in other situations.
And that is all for our questions for the day. Thank you all for attending. Once again, if you do have any further questions, please feel free to reach out to us by email or by phone number, and we'll be able to help you out that way. The slides and the recording will be available on our website in the upcoming days, and you guys will all get a follow-up email with that. Otherwise, have a fantastic day and stay safe.